Okay, we're going to follow this on with a discussion about vertebral compression fractures and vertebral augmentation. So we'll talk a little bit about augmentation. We'll talk a little bit about the typical treatments, including non-surgical management, followed by vertebroplasty, kyphoplasty, and we'll get into some fairly technical information, talk about spine jack, and talk about screw-assisted internal fixation and how to advance the treatment in terms of treating unstable fractures, lytic metastases, giving rise to instability and traumatic fractures as well. So bracing, this is something that absolutely drives me nuts, because this is not bracing for scoliosis, or is it bracing for degenerative pathology? This is bracing for spinal fractures. And there's data on this. And when you do something radical, like actually read the papers on this, they will say it works for a hard brace but not a soft brace, or it works for acute fractures but not chronic fractures. So Kim and Bailey, acute, subacute, hard brace, soft brace, no brace, no difference, no difference, no difference, no difference. So bracing provides very little benefit in people with painful vertebral fractures. There's an article about Rezwuska. This is a meta-analysis that studies the evidence for what is termed optimal conservative management. So that sounds really nice, but if you examine what people do in terms of bracing, rest, analgesics, PT, extension training, exercise, it makes no difference. I lifted this conclusion directly from the meta-analysis conclusion. Insufficient data to recommend optimal conservative management for osteoporotic vertebral compression fractures. These are meta-analyses. I'll present to you the three best ones I know. This is Papanastasiou, this is Hoyt, and these are an amalgam of 52 level 1 and level 2 trials. And the conclusion is, comparing vertebroplasty versus kyphoplasty, there's a few salient things that you should know. People say, well, there's no difference between vertebral augmentation. Yeah, except for kyphoplasty works significantly better in terms of pain relief. It also has a significantly better quality of life improvement, and this is an amalgam of that. This is an article we did a few years back, also a meta-analysis. It doesn't really say a whole lot. I mean, it says basically kyphoplasty had significantly better pain reduction than non-surgical management, which is kind of a no-brainer, but it tended to have better height restoration, and that may seem like just kind of a cursory thing to say, but what does height restoration mean? Is it important? Here's the best data. This is Jan van Meyerhege, short little Belgian guy that's really smart, and he did the surgical free trial and said that basically that if you measure the quality of life in pain and function, and you correlate that with the degree of height restoration, these two are linearly related. The more you restore the height, the better the patients do in terms of pain, function, and quality of life. And it's proportional. To take them from the basement, the lowest performing quartile, to put them in the highest performing quartile, you need about 4 to 6 degrees of reduction. Not much, but especially as an amalgam, if you have 2 or 3 of these fractures, they start to do well. So I'm going to show you this. Those top two are the 2009 New England Journal articles. Now I'm going to go back. So by show of hands, vertebroplasty versus sham. Who has heard of the 2009 New England Journal articles? Show of hands, please. Yeah, so the vast majority, 80% of the room. Are there other vertebroplasty versus sham trials? Does anybody know of any? And you guys, my fellows, be quiet. Can you name one? Can anybody in this room, and you too, can anybody name one? The fellows here for the course. Please, one, just one. There's not one, there's 3. The vertebroplasty versus sham trial was also interesting because it was equivocal. It wasn't that sham did better than vertebroplasty. It just, these were kind of underpowered trials that were later discredited and downgraded to a level 2. And these are 3 trials where vertebroplasty was statistically significantly better than sham in terms of pain and function and other things, quality of life for Vertos 5. Vapor, VOPE, Vertos 5. And for example, Vapor was published in this little known journal. What's it called? Yeah, The Lancet. So why have you heard of the 2009 equivocal trials that were downgraded to level 2 evidence and widely discredited? And we have Bill Clark's vapor trial that has about the same amount of people as the first 2 trials combined, published in the Lancet. Nobody seems to know about it. So these are Vapor Veritas 5 is a chronic fracture treatment paper that just was published in the great journal, Radiology. Familiar with radiologists, which is like 98% of you are not, but this is it was published this year for fractures greater than 12 weeks, statistically significant benefit. So this is up to date, and now you guys are all up to date. Why is this important? Is because we wrote a mortality paper after 2009 because it is just wrong to say that vertebral augmentation somehow doesn't work. And we now have hopefully clarified that. But what happens? About 24% of people were being treated before 2009. 14% of people were treated after 2009. And this is why it's important. When you boil it all down, one of the things that is a very nice attribute about vertebral augmentation is that it demonstrably saves and prolongs people's life. How much does it prolong their life? Edna did a paper in 2011, said between 2.2 and 7.3 years of additional life per patient. Our paper's on the top. Kevin Ong was first author, Kevin Ong, Josh Hirsch, and I published this, 2,077,000 fractures. Edna's both papers are up here. We had one from Ansgar Lang, which is a German paper based on claims-based analysis. In Chen, the lowest amount of improvement for pain, for mortality reduction was 32% for kyphoplasty, 15% for vertebroplasty. The most common, if you take an amalgam, you take all of this data, vertebroplasty reduces mortality 25%. Kyphoplasty reduces mortality 55%. So name something else that reduces mortality by that degree. I mean, you'd have to go to stroke treatment, so something that our interventional neuroradiologists do, to really find mortality reduction to that significant degree. Hindi wrote a 16-paper meta-analysis, said it reduced mortality by 22% after 10 years, that's a whopping amount. And so we got the idea, well, if it reduced mortality this much, then how many people do you need to treat to statistically save somebody's life? We stole this idea from interventional neuroradiology that said the number needed to treat to save somebody from a morbidity mortality from a stroke was X. And so we said, with this kind of mortality data, so how many people do you need to treat before statistically you save somebody's life at 1 year? Does anybody know this number? 15. How many people do you need to treat after 5 years to save somebody's life? It goes down to 12. It's really prominent. So let me shift gears. I'm going to talk to you a little bit about the SACOS trial, which compared spine jack with balloon kyphoplasty. So at the time, these are superiority claims in terms of height restoration, adjacent level fracture, and pain reduction. When this came out, this was the only 3 superiority claims in 34 years of vertebral augmentation. And this came out in a non-inferiority trial of 141 patients. It's extremely hard to do this. So we look at spine jack and we say, yes, it's a bigger device. And Dr. Yoon will demonstrate spine jack today. And it is a bigger device. It's 4, 6, and 8 gauge. It can't be better in terms of pain reductions. Sticking those big things in our poor little patients, how can you do that? Turns out it is better in terms of pain reduction at 1 and 6 months, this column on the right. Statistically significantly better than balloon kyphoplasty. Do you know what kind of a high bar that is? In the EVOLVE trial, our average pain reduction went from a 9 to a 1.4. So to be significantly better than that, you've got to be really significantly better. So the best thing about this is the bottom right here, is the reduction in adjacent level fractures. And this decreased it. It cut the rate of native fracture in half. So this, if you have a patient with a fracture, you do a vertebroplasty on them, you have a rate of adjacent segment fracture of about 25, 30%, right? If you do A kyphoplasty reduces it slightly. If you do a spine jack, it almost cuts it in half, 12.9%. If you don't do vertebral augmentation, what's the rate of adjacent segment fracture? No augmentation at all. It's about 25 to 30%. So augmentation certainly doesn't increase the risk of fracture. It decreases it, especially if you reduce it well. Fractures like this is a Magrelay 3-3 fracture. We go in, we commonly see cementation like this. How do you like that? What do you think about the cement amount? What do you think? What do you think, Dr. Fleming? Dr. Matt Schoenard, you're exempt until next year. Then you'll be on the spot. Middle column is not cemented. People say don't inject cement into the posterior portion of the vertebral body. That is not only wrong, that's mind poison, right? Because if you're looking, oh, it's getting into the posterior portion of the vertebral body, I need to stop. It doesn't matter, it doesn't matter, it doesn't matter, it doesn't matter, it doesn't matter. What does matter is if it goes into the basivertebral plexus. So you're so busy looking at that middle column, the posterior portion of the vertebral body, you're not looking at the basivertebral plexus, which the cement will come out and go, and thankfully it's protected by the anterior epidural ligaments. God put those there so you could do kyphoplasty and vertebral augmentation without extravasating into the spinal canal readily. And you just are afraid to put cement back here, and here's what happens. Has this ever happened to anybody? Resultant fracture. Oh, yes. And it's happened to all of us that do it. It's either happened to us and you've noticed it, or it's happened to you and you've not noticed it, but it's happened. And this requires a lot more cement or additional support because von Mises stresses when measured back here after you cement this anterior column is a lot higher. That's a point of weakness. And so cement to the posterior border. Don't watch the posterior border, watch the basivertebral plexus. This is a misnomer that's been repeated for decades, and it wasn't wrong in the 90s, or wasn't right in the 90s, and it's not right today. And now that we know it's not right, and we know the repercussions, we probably need to change the way that we look at things, the way that we do things, to avoid middle column fractures. This is a very fragmented fracture. Everybody can see this. This is a complete burst, Magrel 3-3 fracture, A4 fracture, but we'll use a Magrel scale for the purpose of today's discussion. This is oligotrophic hypertrophic non-union with very fragmented, with a complete mass of air in it. And this is a snake in the grass. Anytime you see fluid like this, and here's what, just a little bit later with the CT scan, this is very unstable. It is unstable. And either you cement that and you really know what you do, or you provide additional support using a standalone implant, or that thing is going to fall apart on you. So this is one of those things. And if we ask for some help, so you go to your library and you pull out, say you've been in practice for a long time, like Dr. Schoenard and I pull out Mercer's textbook of orthopedics, and we see that, Magrelay 3-3 fracture. Oh, that needs to be treated with conservative treatment or fusion. I can't even say that with a straight face. I mean, you got to be kidding me, right? To treat that, so only A fractures, type A fractures, and an A3.1 should be treated with vertebral augmentation. That is not representative at all about how we treat today, is it? Not even close. Well, so what do we need to do? Do we need to do this? These are perk rods with a point on the end. These are perk screws, but still it's reasonably invasive. So how does this do to stabilize that fracture? So if you measure it, it doesn't do so hot. This is a non-fractured, and the end plate, we did this work in Italy, so this means a movement of the superior end plate. And this is fractured with a lot of movement. This is the same thing I just showed you, and it doesn't reduce the end plate movement very much of the superior end plate. What it does is if you augment it, this is augmented with kyphoplasty and a screw. This is spanning. This is implant plus single level screws, screws to assist internal fixation. And this is the same thing with spanning pedicle screws and rods. So what do we need to do? Do we need to go all the way over to this to stabilize it? Because that has the least amount of superior movement of the superior end plate, least amount of movement. Well, I'll submit to you, we probably don't need to do that. Functionally, a combination of the least amount of movement, that's the least invasive. It is an incident level fracture repair provided. This is not a B or C fracture with additional through and through injury or injury at the levels above and below the incident level fracture. But if it's just a fracture and you need additional stability, this is what's called a pedicle jack. Has anybody seen one of these? No, because we did this in the lab in 2016 and it hasn't seen the light of day since then. And this is screw-assisted internal fixation with a vertebral body stent and a F2 screw coming out of Italy. It's a fenestrated screw made by the Italians. But that seems to be the combination of the way that things are going, the combination of the least invasive thing that provides the most stability. This article by Vanny says the same thing as Mercer, but acknowledges that we can do some B and C type with just anterior column support. This is a subchapter written by Stefano Marcia, 35.9, about doing standalone spine jack and magular A3.3 fractures. And there's 17 references in this, and this is from, it's in the Comprehensive Guide of Vertebral Augmentation book. And here it is. And this looks pretty good. And the greater that you raise this back up and restore the height, the more the column is restored. You can see a little bit of an example right here, and there's good other articles by May, Bloom, and Veneer that say the greater the height restoration you jack it up, the more the canal will open itself. That should be remembered. So people say, I'm afraid of doing this because there's retropulsion of bone. What does that mean? It doesn't mean it's not a surrogate for signs and symptoms of neurologic compromise, but people use it like that, and you shouldn't do it, shouldn't do it. And in addition, the more you reduce it, the better you treat this, the wider the canal will be every single time. So it provided there can be movement because of ligamentotaxis and pulling the PLL. This is an article I did with David Noriega. He's out of Spain. And we took consecutive A3 type fractures that were traumatic, and we measured pain and function, and we measured them as using standalone spine jack for treatment, and we measured it 5.6 years. And we found statistically significant improvement in pain and function that maintained itself over time, and we found that it was stable, held the same anatomic restoration after 5.6 years. So let me show you the difference between kyphoplasty, this 10 o'clock or 2 o'clock approach to the pedicle, versus screw-assisted internal fixation or implant augmentation, as it needs to be flush up against the end plate to be able to push it better. So here it is. This is an example of a vertebral body stent, if you've never seen it. Access transpedicular, put in with the typical needle, followed by a K-wire, followed by contralateral augmentation when you drill ipsilateral, drill contralateral, put vertebral body stents in, reduce, 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 very nice, add cement, and do some prophylactic levels. And this is what you get. Very nice. And this is a very typical case. This provides a tremendous amount of stability for this traumatic fracture at the incident level. And the adjacent is just due to the fact that the person was osteoporotic. It's called screw-assisted internal fixation. So does this have literature associated with it? Yeah, at last count, it has 9 articles associated with it. And for the function of traumatic, and for the function of neoplastic, and for the function of very fragmented osteoporotic type fractures. And in fact, this is the area that it works really well. It works well for these categories: very fragmented osteoporotic, lytic neoplastic, and traumatic fractures, and it leads to central canal decompression. It's very nice. So in combination, this is the least invasive way to treat the incident level fracture that provides the greatest amount of stability. So to summarize, pull it all together, non-surgical management essentially has no support in the literature. So the insurance company that's making you do bracing, rest analgesics, and other conservative care, including Medicare until the last LCD came out, doesn't really know. And maybe that's why in the last LCD, Medicare changed to allow acute fractures, because there is data on that. Kyphoplasty is better in terms of pain, quality of life, and fracture restoration, and decreasing adjacent level fractures, especially the implants. Implants are a new horizon. They're demonstrably better than balloons. They're definitely demonstrably better than vertebroplasty. And implants should be used in the conditions that I just measured in terms of vertebral body instability. They can be used as a standalone to treat most, if not all, A2 fractures. And they can be used as a standalone to treat all A-type fractures, including Magrelay 3.3 fractures. And the greatest amount of stability with the least amount of invasiveness is screw-assisted internal fixation. So, vertebral augmentation is one of the most effective things of anything we do. It's the only thing I know that I do that's demonstrably life-saving and life-prolonging, and it is overwhelmingly supported by literature, whether you know it or not. And hopefully today we've learned something about, especially about the vertebroplasty literature that's been present since 2009, but yet not well discussed. And my message to you is do more vertebral augmentation. Your patients will love you for it. Questions, comments? Snide remarks? Dr. Fleming.
Question and snide remark. And I'm going to ask this until you answer that I like. Why do we still not have vertebral body stents?
So we should. They're made by Johnson & Johnson. They came out in 2010 and did an IDE trial with this. It was done by a guy named Werner, W-E-R-N-E-R. And they did it with a prototype. And they had no better performance than balloon kyphoplasty because their balloons weren't strong enough to expand the stent. They used a prototype. They had a lot of breakage in the equipment. Anytime it breaks, that's a device-related adverse event. And so just kind of a careless trial. Believe it or not, that's the fact of the matter. And we definitely need something. I'm tired of looking at the pedicle jack that we did in a lab in 2016 with Guillaume Duterte from France. Every time he asked me, oh, what happened to the pedicle jack? And I'm like, you know, I wish I knew, but it's certainly not coming out. And we need something. If we have to cobble it together ourselves, that's what we're going to do. And that appears to be what is going to happen. We just have to develop it ourselves. And there's better, the stent is made out of cobalt chrome. It's a terrible material for a stent. It needs to be made out of more alloy or maybe, you know, titanium alloy, but something better than cobalt chrome. So there's new stuff coming down the pike. There's shaped balloons. There's stents that fit over balloons, and these balloon within balloon technology has PSI up to 2,000 PSI for the low compliance balloons. Good stuff coming out.
Doug, I have a quick question. So
Yeah.
the concerns, as I understand what you're saying about the retropulse fragment, just not a big deal. Just because you're going to stabilize it, it's a non-factor.
Yes, non-factor. And I don't understand why we're still afraid of what is retropulsion. You know, what does that mean? Well, to me, that's how the cookie crumbles. So you have the interpedicular segment that goes back whenever the spine, the vertebral body scrunches down in the front. That's how it's supposed to happen. It's normal fracture. And it is not a surrogate for signs and symptoms of neurologic compromise, but people want to make it so. They want to say, well, I'm worried about the retropulsion. Okay, show me a case. Show me one. Show me a real case. You know, I've never, ever seen in anybody that tries to restore the height of a vertebral column with an attacked PLL, does the fracture fragment go retro? Just doesn't happen. Ligamentastasis is the accordion effect. It pulls things together, pulls it from front to back. And the PLL is pretty robust. Neil?
Yeah. So that original confusion came from Bernice Hecker, who was the director of Noridian back in 2014. And she put it in, and you and I were effective at getting it removed. She put it in as a contraindication to cement augmentation based on a fear that the insufflation of the balloon or the injection of the cement is going to push the fragment back. But in fact, the ligamentastasis of the posterior longitudinal ligament pulls it forward. And the data from operative treatment of burst fractures also shows that to be the case. So it was a well-intentioned, misinformed, undereducated bureaucrat. Yeah, that was it. That set a ball rolling. We now have payers who are doing the same thing. With Medicare, you can show data and force the reversal of an ill-informed opinion. You can't do that with payers. Payers can make their own decisions around what they consider experimental or not. So it's absolutely important that when you practice, that you participate in gathering data that shows overwhelmingly the benefit of what you do.
So Neil, I'm going to transition to the lab, and why don't you pass on in that exact vein? So as much as Dr. Hecker had played a downside in our role in the treatment of vertebral augmentation, she did play a strong upside in our ability to save that whenever the LCD was threatened in 2015. So you want to?
Yeah, so Bernice actually became an angel because she recognized that the amount of information that was coming out of more than 1,094 patients, which were her patients because they were all out of Noridian. So west of the Mississippi, the Medicare is divided into regions, and west of the Mississippi all the way out to Hawaii is Noridian. And we were showing them the data on outcomes, and there were some of the most significant outcomes that had been recorded in any surgical procedure. And the concern for the legitimate angst that she had over the retropulsion is, would it cause paraplegia? And in the 735 patients we published, there were no neurologic deficits. So it was a theoretical angst that had no clinical manifestation. There's no experience of that. And all of these women demonstrated such remarkable improvements that it became very impactful in Medicare to look at large data sets. So one of the things I'll be talking with you about tomorrow is participating in a collaborative that gives you large data sets. You have enormous opportunity in your spinal cord stimulator arena where there is a dearth of the embrace of this method of investigating and identifying what works and what doesn't work. Any questions? Yes, please.
I have a logistical question about how a lot of these patients find their way to pain doctors, because in my experience, a lot of these patients get, when something happens acutely, they get diagnosed in the ER. And in trauma centers, usually it's sort of neurosurgery, not pain that's plugged in. And then by the time we see these patients in the pain clinic, it's already an old fracture that's sort of out of the window in which it can maximally benefit. So I'm just wondering, and I'm sure it varies by institution, how these patients find their way to pain doctors.
So if we're talking about vertebral compression fracture patients, Doug alluded to a study that shows that even as you get further out, you can still snatch victory from the jaws of defeat. And that's really quite true. And I'll show information tomorrow that actually has financial information associated with it. So in health systems, you have to, if you're participating in a health system, you have to identify the pathway that the patient travels. And sometimes you do have to go to the ED, and you do have to talk to them where they're having their group meetings and talking about how they're doing things to inform them, because they may not have the bandwidth to have looked for this information, and so they don't know. And they're glad to participate once they do know. You do have to talk to your primary care physicians who remember the Coleman's and Bookbinder articles that said, oh, this is a sham. That's the only word they remember. That this is a sham, and treating these people as a sham, yet they have seen hundreds of women coming in pushed by their daughters and granddaughters in wheelchairs with a vertebral compression fracture. So in a way, it's part of that collaborative mindset that I mentioned earlier, that you should collaborate with the individual on your left and on your right and in your community, because you can then raise that awareness, and with that awareness comes a flow, and with awareness of patients to you. And equally importantly, with that awareness comes a trust in your judgment, and that is huge. Yeah.
Yeah, that's a great question, because when you're in fellowship, you're used to patients coming to you with conditions. And as you go out into this world, whatever you do, whether it's in academics, private practice, or hospital network, you have to figure out how to get patients to you. And so I'll tell you my story. I was, this was 8 years ago, Doug gives a similar talk about vertebral compression fractures and augmentation. At UCSF, when I was on faculty there, IR did all of it. I wasn't allowed to do it. I got trained by Kyphon once, and I never did a kyphoplasty for 5-6 years. Doug was the one to push me to do it because of the NNT that you saw there. So I started relearning how to do it. And now I do vertebral augmentation all the time. And I had to go out to the ERs and teach them and tell them, I'm available. So basically the workflow is, if it's an emergent or neurologic deficit situation, it goes to neurosurgery and IR inpatient. But most of the time, those patients are discharged and have a referral to me within 1 week. You have to make sure you're available, right? So you don't want them waiting a month to see you while they're suffering. So you need to make sure you get them in quickly. But now we have that great workflow, and I do spine jack, and the IR guys don't. They just do BKP. And so if they see a patient who would benefit from spine jack, now they send to me. They'll call me up and say, hey, this is the way it goes. So it is really important to, figure out the pathways like Neil said, but I'm just giving you an example. I didn't do any of that stuff. I developed it, and now here I am. So that's just the way the world works, and that's how you get it going. It's basically because Doug forced me to.